Intracranial pressure is the force exerted by brain tissue, cerebral spinal fluid, and blood within the cranial vault. Our ICP, intracranial pressure, is constantly fluctuating in response to exercise, coughing, straining, and even our respiratory cycle. The pressure is normally 0 to 10 millimeters of mercury. We can measure this by inserting a catheter into the ventricle and hooking it to a transducer, or a bolt inserted into the subarachnoid space, an epidural sensor, or an anterior fontanelle pressure monitor. Very high ICPs are usually fatal. Up to 20 millimeters of mercury can be tolerated briefly. 20 to 40 requires intensive intervention and can be accompanied with negative outcomes. Anything over 60 is typically fatal. The fear is herniation of brain matter through the foramen magnum into the vertebral column. We'll look at several things that can cause our intracranial pressure to be elevated. Things such as an intracranial mass, a foreign body that's not supposed to be there and it's taking up space, such as a brain tumor, a contusion, an intracranial bleed, or abscesses. If we think about generalized brain swelling from an ischemic, anoxic injury, such as drowning, diabetic ketoacidosis, or Reye's syndrome, that's also, the inflammation is space occupying that shouldn't be there. We could also have an obstruction to flow of cerebral spinal fluid and or impaired absorption of cerebral spinal fluid, such as occurred in hydrocephalus. These are all contributing factors to elevated intracranial pressure. What symptoms might suggest that someone has an elevated intracranial pressure? You can find these descriptors in your book on page 1652. Please study the table 56.1. Infants can display a bulging fontanelle, irritability, a high-pitched cry, a change in their feeding pattern. These would be early manifestations. A late manifestation would be setting sun eyes. An older child will be able to give you verbal complaints about a headache and photosensitivity. It is important that we recognize the early signs and not allow a child to develop bradycardia, impaired motor and sensory responses, abnormal pupils, abnormal respirations, and coma. Cushing's triad is a late sign of increased intracranial pressure. When we see these symptoms together, we know this child is very sick and requires immediate medical attention. But more importantly, we want to recognize those early signs and not ever allow a child or an adult to get to these extremes. The medical management for treating increased intracranial pressure. Sometimes in situations when only a small amount of cerebral spinal fluid needs to be drained off, then a lumbar puncture or a ventricular tap can be done. It's obvious to you that these are sterile procedures. If the elevated pressure is secondary to a hematoma or a tumor, then evacuation of the mass or the accumulated blood is indicated. Sometimes a hole is drilled into the skull to relieve pressure. This is called a craniotomy. Another intervention that's tried is hypothermia, cooling the body to temperatures less than 95 degrees, quiets the brain. Another way to bring the pressure down is to provide ongoing removal of some cerebral spinal fluid by inserting a catheter into one of the ventricles. You can set the ICP monitoring device to automatically allow excess fluid to flow out into a drainage bag if the pressure exceeds a certain amount as indicated by the physician. This is also called an intraventricular catheter or an IVC. When all else fails, a decompression craniectomy could be performed. Do you know where they store that bone until they can put it back in the skull? Medications such as osmotic diuretics provide temporary relief in an emergency. The effects only last for about 6 hours because albumin and mannitol are rapidly excreted by the kidneys. They carry a large amount of water and sodium with them. So, knowing that, what do you think the nursing implications are? Did you say watch for signs and symptoms of dehydration and monitor electrolytes, especially sodium? Another medication is a barbiturate drip, which induces a coma, which quiets the brain. Beware of the depressive effects on the cardiovascular and respiratory system. This child will most likely be intubated on a ventilator. So what are the ongoing needs of a child who is completely dependent on you for everything because you have suppressed their level of consciousness? They depend on you for airway patency, nutrition, appropriate stimulation. Protect their eyes because the corneal reflex is absent. Prevent complications from immobility. Non-pharmacological and non-surgical strategies to reduce ICP include keeping the head of the bed up, and the head must remain in line. Avoid neck extension, neck flexion. Keep it in a neutral position so that nothing is impeding the gravity flow of ICP. No roughhousing, no noxious stimuli. That would include visitors, straining, vomiting, coughing. Sometimes when we have to suction their ET tube, we'll give some lidocaine to suppress their cough. Also, don't flex their hips. Strict intake and output is indicated because not only are they at risk for dehydration because of osmotic diuretics, but they're also at risk for SIADH, which is syndrome of inappropriate antidiuretic hormone, which means they hold on to water. So monitor for this. They're also at risk for another extreme for ADH imbalance, which is called diabetes insipidus, which means they're peeing too much. SIADH is a syndrome that frequently accompanies central nervous system diseases. There's a decrease in urine output, serum hyponatremia, and hypoosmolality. SIADH is treated with a fluid restriction. And as always, don't forget the needs of the parents and the siblings. Remember, we want to meet the needs of the entire family. What are the family's strengths and weaknesses as they cope with their child's condition? Was the child born with a condition that caused increased ICP? Or have they had a healthy child who is now experiencing an acute illness? Will there be long-term sequelae that will impact the entire family? What are the needs of the siblings? You can imagine a variety of scenarios. We want families to be actively involved, to be empowered, and to be educated.